Idil. That's fine. Good afternoon, everybody, all the senior teachers and all my dear friends. Thank you for this opportunity, and thank you to Dr. Nagesh sir for creating this science group, and for Manjunath to like every day be posting something and keeping everybody learning and interested in the group.
You want to know today, whether you learned or not.
Yeah, no. Yes. So I'll be talking about pneumonia in children, the definition, the epidemiology, and the risk factors. So first, coming to what really does the word pneumonia mean? What's up? Yeah. So first, pneumo means air spaces, and EI is an infection of the air spaces. So now what exactly is that? It's the infection of the alveolar spaces, which is called as pneumonia. So usually the lower respiratory tract is taken as anything which is below, which is in the intrathoracic part. So many times we do include like the infection of the bronchi and the bronchioles also as lower respiratory tract infection, and it's sometimes confused with pneumonia. But pneumonia is strictly the infection of only the air spaces. Next, how do we define pneumonia? So pneumonia can be defined either in pathological terms or in microbiological terms or radiologically or clinically. So coming to the pathological definition, so we know that whenever there is an infection by a microorganism, so there is an initial phase of consolidation, wherein there is a lot of cell infiltration into the lungs, and then that is followed by red hepatization, wherein it becomes very hyperemic, and the consistency of the lung becomes almost like the liver, and that is followed by the gray hepatization, which is like it becomes fibrinopurulent, and it is an avascular phase, and finally we have the resolution phase, wherein there are a lot of macrophages. However, it actually is a gold standard of defining a pneumonia, but then we know that it's not practical. However, in autopsy cases where a child has died due to pneumonia, this could be used as one of the methods of diagnosis. The second thing is, by the kind of infiltration of the cells which are there, we could also know whether it is bacterial or viral or pneumal or protozoal or fungal. But this is not a practical definition. Second, coming to microbiological. So microbiological, so what organism stays in the alveolar spaces is not always accessible unless we examine the sputum or we examine the bronchoalveolar lavage specimens. But whenever we isolate an organism, it doesn't necessarily mean it's causing pneumonia. It could be simply present, it could be a part of something which causes an upper respiratory infection, or it could be actually pneumonia, and in 50% of the cases, it is not found. So then we go to the radiological definition of pneumonia. So radiological has been considered as one of the gold standards, but it has its own limitations. It is not useful in ambulatory settings. It can also not always differentiate between viral and bacterial, and in the ongoing management of a pneumonia case, it's not really required in all cases. So now coming to the WHO did define some of the endpoints. They define what are the points which constitute pneumonia. So the first thing was presence of a consolidation, endpoint consolidation. Now what does an endpoint consolidation means? That means there is a patchy, like patch in the X-ray, which shows that there's a fluffy consolidation underneath. This could involve a part of the lobe, the whole lobe, or the entire lung, and there could be an air bronchogram, and there could be fluid associated pleural effusion. That is an endpoint consolidation. The second is presence of infiltrates. Like it could be patchy infiltrates, or it could be linear infiltrates, which are distributed in a lace-like manner throughout both the lungs. And sometimes it could also mean peribronchial thickening and areas of atelectasis. And the third is presence of effusion. When we say effusion, there should be fluid between the lung and the chest wall in the pleural space. It doesn't involve fluid in the minor fissures and in the oblique fissure. So that is the radiological definition of pneumonia as per WHO standards. Now again, the host fact. So the first thing about radiological limitation is it depends on the expertise of the person. First, the film quality itself. Second, the expertise of the person in interpreting the X-ray. And then it is also so many host factors like age, the comorbidities, the immunological condition of the child can alter the X-ray. But of course, X-ray is required in very severe pneumonias, or if there is hospitalization or prolonged fever due to any cause. Suppose there is prolonged fever, you need to get a chest X-ray done, even if the child is not having tachypnea. Then the other radiological modalities are CT scan, and we know now that there is this ultrasonography which has got a good sensitivity and specificity of 80 plus. Now coming to the CT scan, so X-ray also, they did one particular study where about 319 children were studied, and they found that around 100 children had a normal X-ray, but when a CT scan was done, there were infiltrates. And then so many kids were having an X-ray shadow and they were cleared by CT scan. So the so-called gold standard of chest X-ray may not really be true. So because but there is an unfair advantage that always an X-ray is done earlier in the clinical course as compared to a CT scan. However, and what could have caused something positive in the X-ray but then no longer there in the CT scan could be sometimes things like pulmonary fibrosis or some collapsed part of the lungs which is appearing like a shadow which is already there, and it may not be a new finding. So that is what could be the radiological modalities. Ultrasound is quite good, but however again it's not there in all settings, and it may not be useful to view certain medial portions of the lungs, or it may not be useful in somebody who is very like big girthed person. So then we come to the clinical definition. We all know this WHO classification of pneumonia, which was introduced first in 1997, revised again in 2005 and again in 2014. So the latest definition is we either say there is no pneumonia, or there is pneumonia, or there is severe pneumonia, or pneumonia with danger signs. So pneumonia is any child who is presenting between 2 to 59 months, that is 2 to 5 years, with cough or difficulty breathing. So we call it as we classify into two groups. So now the severe signs are like the child is very lethargic, unconscious, throwing convulsions, not able to breastfeed or take feeds, or grunting or head nodding. All these are as severe pneumonia, very severe pneumonia with danger signs. So why is this definition is so important? So definition is very important. First and foremost, to identify a problem. How do we know that something is pneumonia, and how do we define the problem in the community? By a proper definition. Second is when we do a prompt identification of the cases, and if we can start antibiotics, especially in a bacterial pneumonia, it decreases the all-cause mortality by almost 25%. And the third thing is whenever we are studying vaccine efficacy, if there is a low specificity of some diagnostic method, it will underestimate the role which is played by the vaccine. For example, WHO criteria itself, it is having a low specificity and sensitivity. The specificity is around 65%, sensitivity is somewhere in the 56 or 57%. Why? Because tachypnea can be caused by so many other things. It could be anxiety, it could be anemia, it can be reactive airway disease. And coming to reactive airway disease, many children with wheezing would be classified as having chest indrawing and tachypnea. So that is why there is also another added thing that you can give nebulization to the child or give them inhaled bronchodilator maybe 2-3 times and then reassess the child. And lower chest indrawing can also happen in any condition which is causing tachypnea. And then danger signs could be the final common pathway of any illness, not just pneumonia. So what happens is this kind of overdiagnosis in a clinical setting may lead to overtreatment. Then whenever we're studying a pneumococcal vaccine and there is a low specificity, it dilutes the impact of vaccine. So there is another thing which is called as risk scoring, which is risk index of severity scoring, respiratory index of severity scoring, which takes into consideration the age of the child, the nutritional status of the child, the chest indrawing, wheezing, and also the oxygen saturation, and it gives a negative scoring for wheezing. So that has a sensitivity and specificity of almost 70 to 80%. So next, so the conclusion of definition is there is no single definition of pneumonia which is reasonably sensitive and specific and which can be widely implemented. So next, coming to the childhood pneumonia cases in India. So if we look at the trend in pneumonia mortality in India, compared to 1,000 live births, the pneumonia mortality has been dipping over the last 25 years. So it has been coming down. Next is the 2025 pneumonia cases in India. The total number of respiratory infections were around 30 million episodes, and out of which 3 million were severe cases. And under 5 deaths, the pneumonia contributes about 18 15 to 18% of the cases. Then this is 2000 and then 2015. So we see that the number of total cases have come down almost by 41%. So in 2000 it was 83.8 million and in 2015 it is around 49.8. And below 5 years the incidence was 657 cases per thousand, then it came down to 403. And the highest decrease was in Kerala and the largest number of cases were in UP, Bihar and Madhya Pradesh. So the case fatality rate is somewhere around 0.38% for the pneumonias, and severe pneumonia, the case fatality is around 2.26%. Now if you look at distribution of clinical pneumonia cases by state, we see that the blue is something which has got a less number of cases, that is less than 150. Whereas the 150 to 250 is all the white ones, and the yellow is 250 to 350, and the pink, the highest is in Rajasthan, Uttar Pradesh, Madhya Pradesh and Gujarat. What was surprising for me in this particular thing was West Bengal seems to have a lesser incidence than Karnataka, despite Didi. I don't know how. Okay, now coming to the deaths of children under 5 by infectious diseases. So if you see the infectious diseases, pneumonia still stands out as a #1 cause of death. And compared to all the others like malaria, diarrhea, sepsis, all that, the decrease has been quite significant. But pneumonia, it's still, the decrease is not that much. So if you see pneumonia, we still have a lot of work to be done. Now this is incidence of childhood clinical pneumonia at the country level. So the black is the worst, so we are somewhere grey, and we can see that all the developed countries on the top like the North America and the European countries have a very, very low episode per child year. So they have only about 0.05 episode per child per year, whereas we stand at about somewhere around 0.31, and if you see the average, it is around 0.29 episodes per child year. Then this was a prepared study which was done. It is like pneumonia research and partnership study. So this particular study took almost 70 countries, and like there were a lot of studies which are included, about 41 studies which are both community based and hospital based studies, and all these areas were included. Then the basic, so almost 285,000 children were studied in this. And then the conclusion of the study basically was that the age group which is most affected is the 2 months to 1 year children, 2 months to 23 months children. They are the ones who are maximally affected, and males are affected slightly more than the females. I just want to know if somebody knows what does that 0.2 point STU mean. I could not get it anywhere. I couldn't understand it anywhere. So there is that age category less than 2, then there is 0.2 point STU, then pro 23. Does it mean to say it is 2 to 23 months? I don't know what that STU meant. I think that next two columns, 2 to 23.
If you just extrapolate less than 2 months, it will be 2 to 11, 12 to 23, and more than 20.
Yeah, so it's probably more 12 to 23. Yeah. So we see that 2 to 11 months children, yeah, 12 to 23. So 2 to 11 months children were the maximally affected pneumonia episodes, and males are slightly more, 54% as compared to females.
Infants.
Now, mostly infants. So now coming to the risk factors, there's something called as definite risk factors. There are likely risk factors and possible risk factors. Coming to the definite risk factors, it is always the low birth weight. So anybody with a weight for age score less than -2, low birth weight of 2000, less than 2.5 kgs, non-exclusive breastfeeding for the first 4 months of life, no measles immunization, indoor air pollution and crowding. So these have been regarded as the definite risk factors, whereas the likely risk factors we come to like parental smoking, zinc deficiency, mother's experience as a caregiver, and other concomitant diseases like diarrhea, heart disease, asthma, etc. Then possible risk factors are mother's education, attendance in a daycare, rainfall, humidity, vitamin A deficiency, the birth order and outdoor air pollution. Now, if we take this is the global child death from pneumonia by risk factors. We see that the child wasting was the highest. So, being undernutrition is the single most important risk factor for pneumonia. So, the next comes indoor air pollution. Then the outdoor air pollution comes also as a big risk factor. Then, of course, like short gestation, stunting, underweight, breastfeeding, vitamin A and zinc deficiency. So childhood undernutrition, especially child wasting, is the biggest risk factor for pneumonia, which contributes to about 53% of deaths in the 2017. Now, then indoor air pollution has led to about 29% of pneumonia deaths. Now coming to the neonatal pneumonia. Now it is because in the neonates, deaths can happen due to so many reasons. About 3 lakh deaths per year is underestimated, which is actually due to pneumonia, but it is thought of as due to other reasons. So in neonatal pneumonia, it could be congenital, it could be community acquired, or it could be hospital acquired. So now why in neonatal anemia, in neonatal pneumonia, the biggest factor which causes is the low birth weight. Now why does low birth weight? Starting from the number of alveolar spaces a newborn has or a low birth weight baby has, the respiratory system is immature. The number of alveolar spaces are less. The number of macrophages which are there in the alveoli are less. And whenever there is any infection, they have destruction of the type 2 pneumocytes, which leads to surfactant deficiency and which further increases the risk factor. Plus all the immune limbs like the phagocytic function, the number of neutrophils they have, the neutrophil chemostasis, or whether it is the amount of complement they have or the amount of opsonins they have, everything is deficient in a preterm and in a low birth weight baby. Plus they also have defective skin and mucosal barrier. They have decreased amount of secretory IgA and they have decreased transfer of IgG from mothers. This predisposes to neonatal pneumonia. So by knowing these risk factors, it's important that better pregnancy care can be improved. Then small for gestational age, and also they have decreased carbon dioxide chemoreceptor function. So even if carbon dioxide is accumulating, baby will not be able to compensate for that. Plus in small for gestational age, there is placental insufficiency which leads to hypoxia. And there is chronic hypoxia. We also know that it leads to meconium aspiration syndrome and asphyxias. Then all these are further compounded by presence of like anemia. Anemia can decrease the oxygen carrying capacity of the blood. The PDA can increase the lung circulation, which leads to further worsening of the situation. And we know galactosemia increases the risk of gram-negative infections. So congenital pneumonia, it's mostly because of prolonged rupture of the membranes. So whenever there is any colonization, like by group B, Streptococcus, E. coli, all those things, they can ascend up the the vaginal tract, and then it can cause infection of the whole fetoplacental unit. So whenever there is an infection of the chorioamnionitis, it causes what is called as a first fetal inflammatory response syndrome, or FIRS. So that in turn actually causes remodeling of the lung tissues in the babies, and that further exposes the fetus to more damage by other factors. So we know that toxoplasmosis can happen because of undercooked meat or by being exposed to cat feces, and cytomegalovirus, it happens in 2% of all pregnancies, and if they are seropositive, the risk of transmission is only 3%. The baby is affected. However, if they are seronegative, it's almost 40%. And HSV, herpes simplex, it also depends upon, in the disseminated form of HSV, the pneumonia incidence is higher, not in the SEM type or the CNS form. And it depends on the number of sexual partners, the degree of education, and the age of the person. So other risk factors are of course gender of the child. As I told you, male babies are more prone to get pneumonia. The health-seeking behavior by the parents. So they found that the health-seeking behavior was better in Tamil Nadu and Kerala as compared to Madhya Pradesh and as compared to Uttar Pradesh. So people were not able to identify when the baby got very sick, and they wouldn't go to the hospital, so which increased the mortality. Of course, we know immunization. I think Sir will talk about it. Then chronic diseases like if you have sickle cell anemia, any immunosuppression, including the inborn errors of immunity, cystic fibrosis. Now coming to the ventilator-associated pneumonias, This depends upon the duration of the ventilation, the number of re-intubations which have been done, use of nasogastric tubes, and then the length of ICU stay and the postnatal age.
We have 2 minutes left.
Yeah, I'm finishing. Thank you.
Super, that was well done. Thank you so much.
Thank you.
For giving us such a fantastic foundation. So much of research has gone into that talk. Thank you so much. So to build on that foundation, we now move on to a talk on etiopathogenesis of pneumonia delivered by Dr. Manjunath Sharma, popularly known as Manju Maestro.
Sorry.
How about questions? When should we ask? After that, Kashi is summarized.
Yes.
Summarize, sir, ಮಾಡಿದ್ರೆ ಏನು question ಏ ಇರಲ್ಲ.
That's all.
Yeah, I mean, thank you everybody to have joined in. So we'll move on to the next topic, that is the etiopathogenesis of pneumonia. Yeah, I've tried to give a blue theme for everything so that anything which is odd will be differently colored. I always do that, to build that mood. So every slide will have one theme. Anything which has a striking thing will have a different theme. For instance, this one. So this is sponsored by Pfizer. Thanks to Pfizer to have chimed in with our mood. We always wanted to do something for us. Every time, only few of us get to speak in podiums. So this is made only for South pediatricians, South Bangalore pediatricians, so that each one of us who has extreme talent, but they just don't get recognized in a place. So this year we have the pneumonia theme. Probably next year we'll have another theme. Probably, with every possible year.
Ongoing.
It's an ongoing thing. So everybody gets to involve. So that is my idea. So, and thanks to Pfizer to have taken up this initiative to help us out. So today's topic in this talk we'll deal with the etiology, distribution of bacteria and viruses as per the age, and what are the evidences what we have, and presentation of different types of pneumonia, which is basically a topic of Dr. Gnanmurthy. I will just give a gist of it to start with. Yes.
Cut short.
So we will not be dealing much of the non-infectious causes because that's out of scope. Among the bacterial causes, infectious causes, we have the bacteria, fungi and viruses, and occasionally parasites may also be the cause of pneumonia. And Dr. Pranita has already set the stage, what pneumonia is, how it looks like, and what are the different types of pneumonias, and etc. A lot of that has already been discussed briefly. So why this age-wise distribution for less than 3 months, 3 months to 3 years, 3 months to 5 years, and so on? So why is that so important? Because etiology is a function of age. The ones what you get in less than 1 month is not the same what you get in 3rd month, what you get in 1st year or 5th year. With every age, a lot of factors which get influenced. So one is the maternal immunity, then the child's innate immunity and the acquired immunity. All that gets influenced for the inflammatory agents and the bacterial agents which come to the child. So for children less than 3 months, this is a very striking thing what you all have to see. These mimic quite a lot of what you get to see in adults. So you get the Klebsiella, E. coli, gram-negative bacteria, the staphylococcal infections as the predominant causes of etiology in this age group. And for the less common causes, you have the pneumococci, H. influenzae, anaerobic organisms, and so on. And among the viruses, you have the CMV and the herpes simplex. So whatever we have summated, the same thing is seen here. And then for children 3 months to 5 years, this is another age group. This is what we typically get to see in our outpatient practices We have bacterial causes, which are the ones which are more common are the pneumococci, H. influenza, Staph aureus, Klebsiella, chlamydia, and mycoplasmas. Among the viruses, the topmost what comes is RSV, respiratory syncytial viruses. Then you have the para-influenza, influenza, metapneumovirus, adenovirus, and so on. So, how did we even come to this idea that these are the most common ones? For that, Perth study was published in 2019 in Lancet. So that is the Pneumonia Etiology Research for Child Health Project. This was published in 2019. So they conducted in 7 countries, of which 9 sites were selected: Bangladesh, Gambia, Kenya, Mali, South Africa, Thailand, and Zambia. And children between 1 to 5 years were the children who were taken up for this study. And here the nasopharyngeal, oropharyngeal, urine, blood, induced sputum, lung aspirates, pleural fluids, and the gastric aspirates were tested with cultures, and even PCR was taken up. So what they did was to identify those children who had the signs and symptoms of pneumonia, took up an X-ray where it showed up the signs of pneumonia, and then they went ahead and did all these studies, and that's how they got to this understanding. What is striking here is the blood cultures were positive just in 3.2% of the 1,749 cases, and Streptococcus pneumoniae was the most predominant organism for this. In this slide, what we can see is different isolates in different countries, of which what is most striking is Streptococcus pneumoniae, what is the vaccine types and the non-vaccine types predominated the picture. And we also had a lot of Haemophilus influenza typable and the non-typable ones, and the staphylococci as the important causes of bacteria. And viruses, we all had the understanding, the previous thought was any child who comes to you with the signs and symptoms suggestive of pneumonia, start antibiotics. You're not wrong with that. But that thought gradually changed with the introduction of this study. Now what they said was nearly 61% of all the cases were viral origin. And of course, and among that, viruses were less likely common in very severe pneumonia. And severe pneumonias, though severe pneumonias may have some viral predominance, but it is very severe pneumonia. If you see any such case, it is most likely a bacterial cause. And among the viruses, it is the RSV, respiratory syncytial virus, was the most commonest organism which was isolated, which is roughly about 31% of all the cases. Roughly half the viral load was standalone caused by the respiratory syncytial virus. I think Dr. Girish will know it better. He has recently gone through a severe case of viral pneumonia caused by RSV. Yeah. And other pathogens which were more than 5% of the overall etiologic distribution were viral, non-viral combined, which included rhinovirus, metapneumovirus, para-influenza viruses, which included 1 to 4 types. So this is a donut or the nestled circle representation of the same thing. Of all the cases, 61% of cases were caused by the viruses, and pointer, yeah. And 31% of all the cases were RSV. And bacteria constituted about 27%, and fungi and chlorine were not, otherwise non-specified by a few of them. And tuberculosis constituted 6% of all these cases. And then you might ask me, Manjunath, what is this? You are presenting something which is not relevant to our country. You are presenting Bangladesh, you are presenting Gambia, you are presenting Kenya, but why not India? See, all these LMIC countries, low and middle income countries, had a very similar demographic picture as India did. So this becomes a very relevant study even for India.
And there can be overlap also, right? We can have the Venn diagram. It's called Venn diagram, is it? What's that called?
Nestle donut.
It's what I just want. Virus is 61%, clear 27%. These so many cases we got combined pneumonia.
I think, sir, I'll come to, we will come to that in the,
So third study has shown,
yes sir, we'll come to that.
incidentally, we have the CAPE study from Chhattisgarh.
No, sir, next slide is that.
Because you said there's no-
The next slide is that. So, this is our beloved Dr. Joseph Matthew has done this study, and I have a lot of personal interaction with this man, and he happens to be one of the brilliant minds what we get in India. It's such a humble man and yet so intelligent. He conducted a study in Chandigarh. I think Dr. Keshav was there at the time when this entire study was published. It was enrolling about 44,000 children between 1 to 12 years. So what is striking in this study is just about 2% of the cases turned out to be blood culture positive. And the gram-negative bacilli predominated: Klebsiella, Pseudomonas, Acinetobacter, Salmonella typhi. And the nasopharyngeal aspirates had about 15% positivity, which includes Streptococcus pneumoniae, H. influenzae, etc., etc. And the viruses were detected in about 45% of cases. And the idea is, traditionally, it is the microbe, which is the lung aspirate cultures, considered as the gold standard, of which, if you do that way, it is the Streptococcus pneumoniae and H. influenzae predominated the entire scene. And the molecular diagnostics and the nasopharyngeal samples now detect multiple organisms, only complicating the attribution of causality. We may find multiple ones. What exactly is the causative agent still becomes a very difficult thing to comment on.
In that case, why not do nasopharyngeal aspirate culture for all cases of pneumonia, because it's 15% positive rather than blood culture?
We'll discuss all of that. This is it's a recent study published in 2024. It's an adult distribution, not relevant to pediatrics. This is just to say how common or how similar is this picture with those ones who are presenting with in less than 3 months of age. You have the Streptococcus, you have Klebsiella, Staph aureus, and those ones. So if you look at that, these represent a similar picture what you see in less than 3 months of those children. And here comes the picture: vaccination and change of the etiological agents. I think sir is a better person to talk about that than me. But still, we'll have a small word. Vaccination has hugely altered the etiological profile. And nearly 60 to 90% of all the isolates what we get today in some of the developed countries are viral. We don't get to see as many bacterial cases as we would see it in the past. And the non-vaccine serotypes have had a steady increase in its presentation. And then increase in the atypical bacterial pneumonias and the severity of the atypical pneumonias have gradually worsened in last few years. With the approval of monoclonal antibodies like nirsevimab and the maternal RSV, it is going to change further in due course of time. So I think we will skip this. Sir is going to, Gnanmurthy sir is going to talk more about that in his,
You go ahead.
Okay. So viral pneumonias, we all know it. It presents with a very short course, follows, it generally follows upper respiratory tract infection, gradual onset, generally less toxic. If you see a child who is walking, talking, child, laughing, playing around, but still comes to you with a fast breathing, you probably must be thinking of a viral pneumonia than a bacterial one. And usually both the lungs are affected and all the lobes are affected. Lasts generally for about 3 to 5 days and has a spontaneous resolution. In many cases, some of them may progress for severe forms. And streptococcal pneumonia, of course, is a more toxic in its presentation. Rapid progression can have lobar pneumonias, and gastrointestinal symptoms may also be seen in these cases, and we have allotted this topic to Nagesh sir in our next session. He's going to talk more about how different types of pneumonias are going to present.
You've already done it.
Well, so this is a question for the for our group now. When should we have our next class? April, May, June. We'll freeze it.
How many sessions are spread over 1 year? 4, right?
4.
Not quarterly, everything.
No, sir. Their financial year will get over in November.
May we are very much.
So April, sir.
April.
April.
So March holidays are ನಮಗೆ
ಮನೆಯಲ್ಲೇ ಊಟ ಮಾಡ್ಕೋಬೋದು.
And staphylococcal pneumonias will present with empyemas, abscesses, necrotizing pneumonias, and the pneumatocysts formation. And the atypical pneumonias are, of course, atypical. They can present in any fashion. And pathology of pneumonia, I think Dr. Pranita has already spoken in length and breadth of it. We can have 4 types majorly. That is lobar, bronchopneumonia, interstitial, and the miliary forms.
This classification, you're coming away.
No, we're going to deal mostly with the pathologies.
There will not have overlaps, it's okay.
So we have the stage of congestion. It's generally seen between 0 and 24 hours.
Pranita has put it as consolidation. I wanted to just, in your types, you know, it's congestion, state of congestion, and epidemic of consolidation. First one.
Congestion. It's stage of congestion. 0 to 24 hours with fever and chills. Can have fatigue and malaise, and heavy and congested feeling in the chest. You know, whenever any child is coming to us, you know, I tend to ask this question more often than anything. Do you have pain in your chest while coughing? And if it is saying yes, I have pain, you probably are looking into a bacterial pneumonia than a viral pneumonia. Pleurisy, yes. And then we have the red hepatization. You know, as madam said, it's a liver-like thing. It becomes hard between 2 and 4 days with high fever, worsening productive cough, shortness of breath, sharp chest pain. This becomes more and more typical. You can actually make it out just with the symptoms. Yes, this is a bacterial one. Typical pleuritic symptoms. And then the child is more toxic and ill-appearing child. You know, this is not uncommon. Any child coming to us, you know, sunken eyes, breathing fast, you don't think twice before starting antibiotic. You just start and think of anything else after that. You're not wrong if you do that. Correct me if I'm wrong. And then we have this grey hepatization where you have persistent cough. Generally is seen between 4 and 8 days. Breathlessness, fatigue, lower or plateauing of fever, less chest pain, and you can have spontaneous resolution. This case, and the sputum generally tends to thicken in this case. Resolution is generally seen between 8 and 10 days, gradually improving cough, thinning of the mucus, and improving breathing and energy getting back.
Thanks to the early use of antibiotics, these stages not seen anymore.
And occasional cough as the debris gets cleared. So this is a typical bronchopneumonia
Pathology.
where there is suppurative inflammation of the bronchi and exudate fills the surrounding alveoli. Lung involvement is patchy, usually bilateral, and involves several lobes. This is how the pathology is, and this is how X-ray can look like. And the interstitial pneumonia, it's quite obvious. It is a self-explanatory word. Inflammation within the alveolar wall, hyaline membrane lining the alveolar spaces, lymphocyte, and the macrophage infiltrates. And miliary occurs following the hematogenous spread to the lung and multiple discrete lesions, usually throughout both the lung fields. To summarize, newer diagnostics have hugely changed the way we look at the etiology and understand, and so is our treatment guidelines. What we used to do in the past is not the same, and what we are doing today may not be the same in next 10 years of time. So what we have to practice is the current one. And of course, vaccines have changed the etiology in the current day. Clinically, a high index of suspicion is needed to differentiate between a viral and a bacterial ones. Pathology understanding is an important armor to diagnose, treat and follow up a case of pneumonia. And there's an urgent need for bedside diagnostic tools to maintain antibiotic stewardship.
Bedside.
Thank you.
Being on time is a wonderful thing. I just switched on my mic to say 2 minutes left when I saw him put 2 summarized slides, so I didn't have to make that announcement. So thank you, Dr. Sharma, for helping us understand the underlying mechanisms of pneumonia. Now, to streamline the diagnosis and management, classification plays a very important role. So I call upon Bhishma Pitamaha, Dr. Gnanmurthy, to please go on with your presentation on classification of pneumonia.
Because of my gray hair. Gray aeration. So they branded me as a Bhishma. I don't know in what way, what sense. Thank you anyway, Rashmi. But let me tell you, I'm not that old.
ಯಾರು ವೇಣು ಕ್ವಶನ್ಸ್ ಕೇಳಬೇಕು ಅಂತ ಚೆನ್ನಾಗಿದೆ, ಮುದ್ದಾಗಿದೆ ಅಂತ ನೋಡೋಕ್ಕೆ. ಮಕ್ಕಳು ಕೊಟ್ಟರೆ ಕೊಡಬೇಕು ಗೊತ್ತಾಯ್ತು.
Om Sri Guru Pyo Namaha. Firstly, I want to pay my salutation to my Guru, Dr. Kashi ji, in his absence. He has just gone out. Because he is the one man what my wife always look for. Whenever I act anky-panky at home, he knows how to control me. Number 2, on behalf of Bengaluru South, may I invite the first citizen of our IIP BPS, Dr. Raghunandan. Please to come. Dear friends, give him a standing ovation. Come, friend. It's our duty to pay our rich tribute to our first citizen. I want him to walk around, that's why I made it.
Thank you very much. You made me feel very
Awkward.
special and humble. You humbled me. Special. Thank you, sir.
Thank you. Thirdly, I want to thank the Bengaluru South for wholeheartedly embracing me and inviting me and welcoming me to this forum. The reason is, earlier I was in Wilson Garden, very near to Bengaluru South, but now I'm in Koramangala. Neither I'm in South nor in North. Antar Pisachi. Nobody bother about me. And the fourth, mine being a lost topic, have mercy on me. Be with me for some more time. And most of my talks already been taken by Pranita and Manju. So I have very little scope, but yet I'll put my effort. So that's me. So I don't know much about it. Now, let's do a game. Let's start. You being a student, how would you learn? From where do you learn? You learn from anatomy. So how do you classify anatomically? Then, you have lobar pneumonia, you have bronchopneumonia, and you have interstitial pneumonia. And then as you go up to preclinical, you will come to pathological section where you define or classify pneumonia as been told by Pranita, stage of congestion, gray hepidation, red hepidation, gray hepidation, and then stage of resolution where you get revealed. Again, it also tells whether it's etiology, whether it's infective or non-infective. When you go to microbiology, it will tell us whether it's viral, bacterial, tuberculosis, atypical one, so on so. That's regarding etiological classification. When you move to preventive and social medicine, you will consider epidemiological aspect. Then you want to know in which situation pneumonia has arisen. Is it in the community, or is it in the hospital, or it's somewhere else? That's one. And also epidemiologically you would consider age-wise, starting from newborn to the older age. Then when you come to clinically, again you have two types of classification here. One for a screening purpose by the paramedical staff, because WHO says it has to be screened and picked up by the health workers. So you have no pneumonia, pneumonia and severe pneumonia. But when it becomes severe, or when it comes to the clinician like us, then it is our duty to classify it further and add all the adjectives for better management. So it could be pneumonia, simple pneumonia, severe pneumonia, complicated pneumonia. All this will tell us, stratifies us how to manage a case. So that's about, if you put entire thing, you can put in one frame. Okay, this frame. You can put all this. This is what I asked my AA. What are you going to do? And put in one frame. You have by anatomy, you have by etiology, you have a clinical presentation, you have a epidemiological setup, and then all this, will it make any difference for us? Manju gave a topic, sir, you should talk on classification of pneumonia. I was wondering what is to talk on classification. It's so simple. I classify, I've done my job, I'm out. This would have been easy if you were to be a student, when you had a major question, and a person like Nagesh and Sri Lanka, they are very brilliant, they know in and out. The person like me, average student, I always go with the classifications to write any major questions. The reason is, if I know classifications, with all my bullshit knowledge I add here and there, and make up entire sheet filled up. So that is importance for me as a student to classify, to bring out all the answers. Whereas in our clinical setup, we need a clinical framework how to go about while classifying pneumonia. Why do you have to classify? The reason is, pneumonia is not a simple disease or single disease with a single trademark. It is a syndrome. It has got myriad different presentations, different etiological aspects. It involves different, newborns to adults. It can different manifestations, and also it is highly dynamic. Let me tell you, it can start with simple pneumonia. It can land up in all the complications. So it's very, very important to know all about pneumonia that can be explained through classification. And number two, it has got different management strategies. One, to risk stratifications, and also to manage the case, one need to define the pneumonia based on the classifications. I'll let you know how it is. And it improves outcome, and it also tells us the antibiotic therapy and early recognitions. Yes, that's all the whole idea of having your classes, to pick up early and save lives, and to use antibiotic judiciously. So this is our reason why we need to classify. So I told you, it's a leading cause of child morbidity, is brought very well by Manju and Pranita. Its presentation is highly variable, influenced by age, immune status and causative agent. So all this comes under the etiological aspect, and the presentations and the treatment implications also is based on the classifications. So the pearl, clinical pearl, what we need to know about classification, it is just not for academic purpose. It's an essential clinical tool. How are you going to navigate further? Because every day once you make a diagnosis of pneumonia, you need to be open. It can show any ball at any given time, it can become a problematic one. And also to improve our outcomes. So there are 4 lenses where you can attend a pneumonia. I always remember what Jagdish tells very clearly whenever you attend any problem, clinical problem. Starting with etiological agent, if you address etiological agent, or if you address anatomical region where it's causing, and then the severity and also the clinical setting where it is arised. All this will tell us picture how to go about further. Now starting from etiology, all this has been told very clearly. Again I want to show in the bar diagrams, it says from the neonate 1 to 3 months, 3 months to 5 years and above 5 years. If you see, go by age, we can know what are the etiological agents which causes. This as a clinician we all supposed to know and we should know. We cannot escape from this. Okay, when child comes with pneumonia at neonate, what are the causative agent? It is mainly the E. coli and group B streptococcus and to certain extent viral. If you see in all this picture, the virus, as what's been told by PER studies, more than 60% pneumonia is caused by virus. That's what Manju trying to tell. If you go up to 1 to 3 months, it is mainly caused by, again, virus there. Mainly virus in 1 to 3 months. When come to 3 months to 5 years, we have mixture of both bacteria as well as viral. And when come to 5 years, there comes the role of chlamydia. Again, not chlamydia, mycoplasma pneumonia. Even 1 to 3 months, you have a atypical pneumonia, that is chlamydial infections. So you need to be aware of this. So this will tell us the second clue, based on the etiological suspicions, guided by the child age and clinical signs, it is the cornerstone to pick up to choose the antibiotic for antibiotic stewardship also. The next comes the anatomical lens, and this is picked up mainly through radiology, as very, very clearly told by Pranita. So you have a lobar pneumonia mainly caused by bacteria. Then comes bronchopneumonia in both alveoli as well as bronchus involved. They are mainly caused by both bacteria as well as viral. Then you have an interstitials around the alveoli, which are again caused by viral and to certain extent mycoplasma. So if you know radiologically which part of the organ is affected, then you know which germ or bugs is affected, then we can act on that. So the Pearl 2 here is, though it is not very, very predictive, but the radiological pattern of classifications of the pneumonia, it gives suspicion for certain types of pathogen and helps in the extent of the disease also. So both, one it tells what type of bacteria been involved and also the extent of the disease. So this is second pearl. Then come to the third lens, that is in which setup pneumonia occurred. Is it in the community or is it in the hospital? Hospital setup. If it is community, the pneumonia would have occurred in the society where we know most of the common pathogens are streptococcus pneumonia, RSV, mycoplasma pneumonia. This happens. For this criteria, child should not have been exposed to hospital. It should come in the community, is the most commonest one. The second is hospital occurred, where child gets pneumonia within the hospital setup. That for criteria is the child should have been hospitalized at least more than 2 days. Then only if you pick up pneumonia, then you brand it as a hospital. This is the most difficult pneumonia to handle because here we get all sort of resistant bugs. So one has to be very, very careful, and that's the reason for all of us better to be near to the college wherein we will get epidemiological data. So we should be aware of that. And then secondly, if you go further, if the child gets sick and sicker, if the hand land up in ventilator, then you have what is called as ventilator associated pneumonia. This is again the same type of bugs will come, whatever occurred in the hospital acquired. The third is in the most debilitating handicapped children, wherein they get aspiration pneumonia. Then you have a aerobic type of organisms, which are more common. So based on the epidemiological setup, we'll get a very clear picture which type of organism, and among all the classifications, this classification is very, very, very important. The Pearl 3 years, arguably the most important classifications to initiate the antibiotic early and what type of antibiotic it tells us. Now coming to the another one, based on the clinical severity, you have one for nursing people, the paramedical, then for doctors. You have what is called as non-severe pneumonia, other one is severe pneumonia. This will tell us how are you going to manage. If it is a simple pneumonia, non-severe pneumonia, it can be managed at domestic level. If it is severe pneumonia, then it has to be hospitalized. Again, I don't want to go into clinical details, what are they, which you all know very well. So if it is severe pneumonia, it requires urgent hospitalization, we need the help of Raghunath. But a simple pneumonia, alone is enough to take care of it. The pearl here is, this is also most important sorry. The severity assessment is, again I'm telling you, I want to give an example. The pneumonia is highly dynamic. The reason why I'm telling is, in spite of 4 decades of practice, it is not that easy. No child will come with a label of fast breathing and high fever and toxic. I have a child, fever of 2 days, and a 4-year-old child just came with high fever. No focus of infections anywhere. I did a simple bed test, urine test, showed normal. But somehow my intuition was this child doesn't look normal. I got an X-ray done, it showed a deep-seated lobar pneumonia. But within a matter of 2 hours, child was looking more sicker. Then I told, this is not a simple pneumonia, it has to be hospitalized. I hospitalized, managed, by evening child became very bad. Severe tachypnea and child more toxic. Then I called Raghu. I told him, somehow this child doesn't look that simple to me. So I immediately shifted to Sagar Hospital. And believe me, the child had a stormy course of 3 weeks. From pneumonia, it became to necrotic pneumonia. Then that child had empyema thoracic. Child had to undergo all sort of whatever you call, handled by Raghu, I think, is there. The child was with him for 3 weeks. So what I'm trying to impress you people is, pneumonia is highly dynamic. So don't take for granted. Now comes, let's, with all these lenses what we've gone through, I just want to give a simple case, what we all see day to day and how we're going to classify and how the classifications is going to help us in stratifications and risk management. And also, it's a 4-year-old girl presents with 3 days history of fever, cough and rapid breathing. So by definition, fever, cough and rapid breathing tells it is pneumonia. That's for sure screening. And this child is 4-year-old. And this child has not gone to hospital or not been hospitalized. That means it is pneumonia in a 4-year-old child. It's a simple pneumonia. And community acquired pneumonia. On examinations, when I examined, this child had crackle right lower region and plus rapid breathing and also indrawing of chest was there. So oxygen saturation is normal. So how do you classify clinically? How do you apply? You apply the 4 lenses, what I told you, etiological, anatomical. First, let us say with anatomical localizations. Clinical findings of crackles over the right lower chest supported by X-ray, as what Pranitha told, showing consolidations, points to lobar pneumonia. If we go with etiological, we have to consider age, 4-year. It is community acquired. Since child is toxic, it's more of a bacterial. And being a 4-year, and with the thanks to vaccinations strategies and thanks to Dr. Jagdi Kashi going around telling us importance of vaccinology, the bacterial other infections have come down. So Haemophilus influenza out. And streptococcus pneumonia is the only one what we are all looking for. Again, that also will come down with the thanks to Pfizer company where going around with vaccination. So this leads to probably a case of bacterial pneumonia. Now, history confirms no recent hospitalization. So what is it is? It is community acquired pneumonia. And the severity lens, in this lens, child is having respiratory distress. So this comes under severe pneumonia. So all this you put together, anatomically, etiologically, classifications, acquisition and severity, it is a case of pneumonia, it is a case of community acquired pneumonia, it is a case of severe community acquired pneumonia, probably caused by streptococcus pneumonia. It is and also Radiologically is proved it's a lobar. So the final diagnosis is severe community acquired right lower lobe bacterial pneumonia clearly dictates the management, what we should do, and whether child requires hospitalization or not. So all the risk stratifications and the management protocol it gives just only by definition of classifications of my role. Thank you.
Thank you very much, sir, for that clear presentation, integrating everything together and putting it in a nutshell for us.
Yeah.
I'll never forget the way our Central IIP President, Neelam Mohan, introduced Kashi sir. Karnataka, King, Kashi. So I now call upon King Kashi sir to please summarize and tell us the take-home points of today's presentation.
Just I was telling him now, instead of Kashi Vishwanath, you can call him Kashi Vaccinath.
Thank you. I have a small confession to make. Throughout my career, right from the time I entered MBBS till 2 p.m. today, I have never listened to any postprandial session with such rapt attention as I have attended today. For the simple reason, I have to summarize all the talk, and I've been busy doing that. Okay.
Was it a compulsion?
Next session, I am not agreeing for this. So, okay. Well, we had 3 talks, but I think we had something equal.